Because we can absolutely we can talk about anything. It doesn't have to be airway. But so what I thought we would do is a general update, and then we can emphasize certain things that are interesting, and we can skip over things that may not be as relevant or interesting. So for airway management, we need to remember that this is a big topic of which we have four distinct dimensions. So we have mask ventilation, extraglottic devices, intubation, and surgical airways, of which clearly two of these are BLS, ILS, ALS topics, and two of these are primarily ALS topics, but everybody in the room has been around long enough here to know that it's kind of impossible to do any of these procedures without this being a team effort. And we are currently, for example, exploring a special skill for rapid sequence intubation, rapid sequence airway. That is something that the best practice that's out there right now that's been modeled, for example, that was a paper in a paper from Texas by Dr. Jarvis and colleagues, their system, their RSI pre-hospital system requires 3 paramedics on scene. They have to bring multiple people to the scene, but and then they actually assign the checklist role to one of the non-medics, usually the captain, to do the person who's absolutely running the checklist, and then obviously lots of people are involved in the BLS care of that patient in the meantime. So these things are big team efforts. So even when we get into the ALS side, everybody has to be on the same general page, because it's not going to be something somebody's going to be able to just super medic run in and do by themselves. So let's talk in order. We're going to talk about those things, and we're going to start by talking about mask ventilation. And this is a picture, it's kind of, projects kind of small here, but this was a picture that I snapped in the ER, a year or two ago, and it was just, I happened to see that somebody was set up for an airway case, and I just happened to see their setup, and this little thing actually made me really happy, because what we have here, right, is, what's this? Peep valve. And yeah, I mean, it's just, stuff that, a few years ago, and in many places that's still, crazy talk to be doing capnography during mask ventilation, which we'll talk more about, which should be the norm, and, as well as PEEP. So that made me really happy to see that somebody had that set up that way. So to do mask ventilation optimally, there's really kind of 4 critical factors in this. And mask ventilation sometimes goes really easy. Most of the time is not that hard. But then there's the patients who are incredibly challenging to mask ventilate. And those are the ones where you have to really pull out all the stops. So if you practice this all the time and do it this way, then you're set up for those patients where you really need to pull out all the stops. So just go back here for a second. So just to review, we need a fully open airway. If your airway is not open and basically the air is going to go path of least resistance, which is where? Stomach. Or it's just going to shoot out around the mask. So I'm not sure which is worse. Probably the stomach is even worse. But it's not going to go where you want it to go. So you need a fully open airway, a tight mask seal. We're going to spend a little more time on the appropriate volume and monitoring, because those don't get the same amount of attention. In terms of positioning, we really want to have the patient in this kind of position, which of course, if you're in C-spine percussions, that's out. So patients who are in C-spine percussions are not only difficult to intubate, they can be difficult to mask ventilate, which is unfortunate. Because this is a classic picture that's used for describing positioning for intubation, where you're trying to get your oral axis, your laryngeal axis, and your pharyngeal axis as lined up as possible, because you're trying, in the old direct laryngoscopy days, you're trying to see from here to here. And then you use a laryngoscope as the last sort of step to sweep the tongue forward. That's the axes. But it turns out that that's also a great position for mask ventilation. Because if those axes are sort of aligned, least resistance for airflow. And that usually in adults, older children and up, usually requires something behind the head to achieve that position. Again, if they're not in C-spine precautions. And I see us all the time on cardiac arrests, trying to mask ventilate patients who are often not the perfect habitus, and now they're lying flat on their back. And so any little advantage that you can put in there is going to make your ventilation easier. First, let's cross this off our list. All right, let's see. How about reminding me tomorrow? Okay. Now, the other way to do this is on a stretcher. If you take somebody on your gurney and you slide them all the way up till their head is falling. Did I put that? I may have that picture in here. But if you take somebody while they're flat, put the head of the gurney flat, slide the patient, again, who's not in C-spine precautions, till their head is flopping off the end. Okay. Then sit them up to about 30 degrees. You will get them in that same ideal position with the added benefit that you're going to take the stomach contents and take that pressure off the diaphragm and open up more lung space. So this is actually physiologic and biomechanically advantageous. Now, we're not doing that in cardiac arrest patients, but if you are transporting a patient that you need to mask ventilate, which could include a ROSC patient, who for whatever reason you don't have an airway in, or you just have somebody you need to assist their ventilations, that's a great option compared to this. It's generally a lot easier to do. But we really need to think about getting the patient in an optimal position. Now, in terms of opening the airway, I don't know if some of you have seen this video. This is a difficult airway course video. This is fluoroscopy. And I just want you to look at this for a second and then just kind of wrap your head around what's going on and see if you can figure out the point that's being made. So what's happening here, so video decided to not keep playing. Let's try. So the point of this was, I don't know why it would play for a while and then not play. Let me go back and come back to this. So this is wide open airway. That white space is wide open. This is the old-fashioned head tilt chin lift position. And then we have the jaw thrust. Whether you're pulling forwards or you're pushing up under the corner of the angles of the mandible. But the point that this video makes is that even if the patient is down like this, if you pull the jaw forward, you get some opening of the airway. The whole head tilt, look at how much airway there's open there, and they're not even in this position. But if you do the head tilt chin lift that we were all taught probably in first aid class when we were, in high school or something, does absolutely nothing to open the airway. The obstruction to the airway is what? The tongue. The tongue goes where the jaw goes. So it's all about moving the mandible. And so the whole thing that, doesn't do a thing. Now, if you do that and lift the jaw, great. But the same thing is if you put the patient in that sniffing position, but don't lift the jaw, you don't get a lot of benefit. It's all about moving the jaw forwards. Positioning is an add-on to that, but have to move the jaw. Airway adjuncts, I think we're pretty familiar with these. I think as a system, we're pretty good about using nasal airways. Some places don't seem to like to use them, but this is a great tool just to remind you that there is nothing wrong with a nasal and an oral, or two nasal airways, or 2 nasal airways and an oral airway. I mean, I don't do that in most patients, but there are a few where I just need everything going my way because I just can't keep that patient's airway open otherwise. And maybe a classic example, somebody has too much gag reflex for you to put in an extraglottic airway, but it's one person is having to manage the airway and it gets a little old to trying to keep the job and all that. A couple nasal airways in that patient can go a long way. So multiple airways are totally appropriate. Sometimes you can ventilate somebody easily with no airways. So you have to be constantly reassessing and seeing what else you can do to improve the situation. This is something that I've talked about here before, but I think even for me, it's something that's sometimes hard to just remember to do every single time. But most of the time when we take out a bag, it has a mask attached to it, or somebody hands it to you and tries to do you a favor by attaching the mask before they hand it to you. It's actually intended to put the mask on first, spread it, put it on the face, get a good seal, and then attach the mask. That almost never happens, but if you just take the mask and set it down on the face, you may get a good seal, but you may get a terrible seal. So little things that you can do to make that better is to put that on first and then attach the bag, hopefully with capnography in line. And then in terms of mask seal itself, if you're doing one person, you have to do the old-fashioned EC grip. It's really the only way to hold a mask with one hand if you're also squeezing the bag with the other hand. You can also, better is to have one person dedicated to the mask and the second person or machine, because in our case we use a lot of ventilators, is doing the ventilation. So however we free up one person to have 2 hands on the mask, that creates a better seal in most cases. We have a few providers here with unbelievably big hands, and I remember, I'm pretty sure it was a Matt Carlton case where we were doing bag mask ventilation all the way from Fives area all the way down to UNM, and I was trying to we had lots of time, let's model really good behavior, let's work through perfect mask ventilation, and then I'm like, okay, so we should probably do 2-person, and then I look at this and I'm like, no, okay, that's 2 hands are not going to accomplish anything more than he was accomplishing with 1. But in general, 2 hands on the mask, but this grip, and so this is stuff that's hard to do in this situation. We really should be, I have to get the muscle memory and practice it on mannequins, but holding the mask thumbs up like this and putting this big beefy part of your hands to hold the mask down, and 4 fingers instead of 3 is a much better position for mask ventilation. So this is the worst situation. These are better. I really encourage you to try thumbs up for bagging. And then, so we talked about kind of working through optimal mask ventilation. So part of it is opening the airway really good. Then it's getting a really good seal, right? Pick the right size mask, open it up, put it down on the face, hold it in a mechanically advantageous position with the idea that you are pulling the jaw up, not pushing the mask down, right? It's all about moving the jaw. If you just put all of your force into pushing down on the face, you'll probably get a good seal, but you're not going to get any air into the lung. It's all going to go into the stomach because you have not removed that tongue obstruction like we saw in that video. So the next thing in terms of optimal mask ventilation is to give just enough volume. And this is something that we've hit on here for years, which is this was the whole concept behind moving to the ventilator in the first place, is knowing that ventilation kills patients. How does ventilation kill?
Overventilation?
Yeah, how does overventilation kills. That's a good point. Ventilation is a good thing. Overventilation kills. So thanks for that. How does overventilation kill?
Does it allow for proper exchange, or is it too much?
Losing the elasticity by bagging.
Good thoughts. What else we got?
Does it put too much pressure on the heart?
So You're closer, definitely closer. Why do we use ventilators?
Get a consistent amount.
So, well, we want a consistent amount, but we're really trying to avoid too much, which is doesn't matter how experienced you are, everybody left to their own devices overventilates patients in terms of both rate and volume. But we're particularly concerned about volume more than rate. Why is putting too much volume into the lung an issue?
Possibly pop it.
Okay, so at an extreme, you could cause lung trauma. Okay,
Not in pressure, not at the release. Proper amounts of CO2.
okay. No, in fact, we're going to release too much CO2 if we overventilate. But so that's one thing you can do is we can blow off too much CO2, which is unfortunately causes brain vasoconstriction. Most of the people that we're bagging, they don't need any vasoconstriction of their brain. They're already probably having trouble getting circulation to their brain. But there's an even bigger issue.
Putting too much pressure on surrounding area?
So it comes down to pressure. So a few of you have hit on pressure.
Coronary?
And and it's going to tie into coronary perfusion, but when you put pressure, when you fill up the lungs with air, okay, that's right now when I breathe in, I fill up my lungs, that's negative pressure, right? So I'm expanding my chest, I'm creating negative pressure, air gets sucked in, okay, but that negative pressure does something else. It doesn't just suck air into the chest. What else does it suck in? It actually sucks blood back to the heart. So every time you breathe in, it's not just air coming in, it's blood coming back in to the right side of the heart. When we switch to positive pressure ventilation, every time we fill up the lungs, what happens to return to the right side of the heart?
It's not coming to the heart.
It goes down. Yeah. So, and we can see that very clearly. You have somebody in the ICU who has an arterial line in. Every time there's a breath, you can see the correlation to blood pressure. But if you have somebody in particular who has no blood pressure, and every cc of blood return is, you need every little bit. Every time you fill up the lungs with air and positive pressure, you're decreasing venous return. And if you think about it, the only venous return you're getting is basically from CPR to begin with. That's a problem. So the best case would be we would put no positive pressure in the chest at all. That's kind of a bit of a problem, right? But that's kind of compression-only CPR is kind of based upon that concept, but that's just not sustainable for long periods of time. So every time we put a breath in, we're giving the patient oxygen, and we're screwing up their blood pressure, whatever pressure they have. So there's kind of a sweet spot where you want just enough to provide oxygen, but not blow off too much CO2, but also not decrease venous return, which is then going to affect cerebral perfusion, it's going to affect coronary perfusion, it's going to affect all those important factors. So it turns out that the amount of volume that you really want in a patient in general, there's a few differences in conditions, but in general it's about 6 cc's per kilogram of ideal body weight. Okay? So you figure what's ideal body weight for most of our patients, okay, if there is such a thing as 7, let's say it's, male, female, height difference, whatever, probably between 60 and 70 kilos, maybe 80 in some cases. That's their ideal body weight. That's their inside lung size, because as you get huge, your chest cavity doesn't get bigger. So if you think about it, take somebody who has 70 kilos, 7 times 6?
42.
Oh, is it on here?
No.
Oh, I thought you were pointing it out like it was. So about 420 cc's of volume. How many cc's of volume are in the self-inflating bags? The reservoir, the reservoir? So it depends. I don't know the brand for the one we have here, but it's anywhere between 900 and 1800 cc's are in a standard adult resuscitation bag. So if you're squeezing the bag, especially if you have one person on the mask, so you have another person who's doing the bag and they've got two hands and big hands and there's adrenaline, right? Every one of those breaths is probably, we're giving them, 1,000 cc's. Way too much volume. Venous return is just, every time you squeeze the bag, you can think of this back pressure of just picture the blood flowing back in the veins, back to the feet. Okay. So when you're ventilating, if you're not using the ventilator, which we can control this, we were taught for years, look for chest rise. But the truth is, a chest rise should not be easy to see. If you can see the chest rise across the room, right? Too much chest rise. If you're kind of the person running the scene and you're standing back and you're kind of looking at it and you can see, oh, good chest rise, that's actually not good chest rise. Right? You should actually have to be kind of like, are you really ventilating the patient? Oh, yeah, okay, that's good chest rise. Okay. The other things you can do to make sure you don't overventilate is to use just one hand. So unless you have a small hand, think about using one hand on the bag. There's some evidence on mannequins, not on patients yet, that using a pediatric, not the infant, but a pediatric bag for adults is a better way to go. And I do know some places that have gotten rid of their adult bags altogether just to try to minimize overventilation. And the ventilator, which we have as an advantage that we have that readily available. But what are the volumes that we set the ventilator at?
600, 700.
Depends on the size of the LMA.
So it depends on the size of the LMA. That's how we set this up to make it easy. But if it's a 3 LMA, 300, 4 LMA, 400, 5 LMA, 500. Well, if you think about it, that's where that number came from, right? We're looking at somebody who's about, on the 3 LMA is somebody who's going to be about 50 to 60 kilos. That's where that comes from. A 4 LMA is going to be somebody who's around 70 kilos ideal body weight. And a 5 LMA is going to be somebody who's probably closer to 80. So that's where we came up with those easy numbers. But it's based around, and there's a range around, it's exactly 6, but it's around 6 cc's per kilo. Some people go down as low as 4 cc's per kilo on the ventilator in the ICU for these patients. Dave?
Is this really, why do they make the adult bag so big?
So it's a great question. Why do they make the bag so big? This is just historical practice that is finally changing. Now there's these things called smart resuscitation bags and all these things where people are finally building in pressure sensors. They're building in lights to tell you how fast to go. Some of them are building in capnography. They're building in smaller technology, it's taking a while to catch up. But it's finally, I think, but the classic ambu bag, that's a good way to kill somebody. Yeah. And then in terms of rate, you really want about 10 breaths per minute-ish, right? We set the ventilator 8 during the arrest, 16 on ROSC, okay? But it's, somewhere around 10 breaths per minute is what you want. The studies would say that when we just take and videotape or have a research assistant watching people do resuscitations, that some of that's been done pre-hospital, most of it's been done in the hospital, and you look at how fast people bag during codes, what do you think, how fast?
Too fast.
Too fast, okay, give you that. How fast, give me a number.
24.
20, 24,
30.
30? Wait, the goal's 10 and you're saying we're going 3 times as fast. 30 is kind of hard to do, right? It's like barely time for the bag to deflate.
32 seconds.
Most of the studies would say it's over 40. And let me tell you, every one of you has ventilated a patient at 40. Guarantee it. I've got great video of myself in the ER, real patients. I'm like, oh shit, right? But as soon as I got distracted, You know, I'm doing this like really, I know the video's on, it's a teaching video, I'm trying to be careful, and then all of a sudden I get distracted with something else, and I'm talking to, here, why don't you set up that and give this much medicine, and then I watch, I'm like, it just happens, right? The ventilator doesn't get distracted, right? So this is super important. That's why I spent that much time on that slide, but we don't want to over-ventilate our patients. That's why the ventilator is our friend. But one of the ways we can look at this is, I mean, I'm sure many of you have gotten comments from me in QA about your ventilation rate. How do I know what your ventilation rate is? Do you think I'm looking down on the column on the vital signs where it says, you know, heart rate and ventilation rate? No, I mean, because that's kind of close to worthless, right? I mean, that's like generated by the, you know, the leads generating a respiratory rate, right? How do I know what your respiratory rate is? Is it the drone that I send to each call to just watch? How do I know?
Just how we document it.
I don't trust your documentation, sir.
Can you see on the EKG?
What?
Can you see on the EKG?
Not an EKG. Capnography, right? You should all be looking at the same thing, right? You can just tell right away. We know exactly how fast you're ventilating the patient. And when somebody's on the ventilator, you see these really long exhalations, and you see, you know, on the little 6-second strips that print out, you see like one breath. And if I pull up and I scroll through, and all of a sudden I see a little, it's like, you know, it's pretty easy to tell we're overventilating. We all do it. All right. So this was like, as I said, one of the studies that actually compared just using how many fingers, adult versus pediatric bag, trying to do just one finger on a side, two finger, obviously a thumb. You have to have something on the other side, but it's a thumb and one finger, thumb and two, thumb and three. The median volume that was delivered with 3 fingers on an adult bag was 836 with the bag that they were using, but some of the bags absolutely have bigger volume. When they went to a pediatric bag, look at this. Everybody was still overventilated for adults. So it's pretty interesting. We do, and I assure you, we do a way better job of this in EMS and in this department than we do in the hospital. Yeah.
Will there be services that are potentially moving to a pediatric bag?
Yeah, and we actually talked about it at Lifeguard. We actually talked about taking the bag, the adult bag, out of our bags. We haven't done it, but I can't give you a service name, but I know that there's been some kind of listserv discussions, and somebody said, oh yeah, we got rid of that bag and whatever. But I think in our case, since we have a ventilator, I would rather, you know, not make a drastic thing of pulling the bag, but just encourage people to use that tool. For places that don't have the ventilator, that probably becomes more important. All right, so we worked through these things, and then monitoring. So these are the things that we should be doing. This is like, for an example of one of these kind of smart bags that has a pressure manometer on it. It has the PEEP valve built in. These are they get pretty fancy. So you should be listening and looking for air leaks when you're bagging. This idea of a subtle rise in the chest, right? Again, you shouldn't be, and doesn't, even on a thin patient, it should be subtle. Compliance resistance pressure. Ideally, we should have a pressure manometer, and I think more and more we'll see bags coming out that have these manometers built in to tell you how much pressure you're giving. Lung sounds as appropriate if it's not too noisy. Saturations, if you can get one, right? A lot of times when we're bagging, it's a patient and we don't have a good sat, so that's a problem. And then capnography. So I want to spend a second on this. Anytime you see a patient being mask ventilated in the OR, they're on capnography. I'm trying to make it that way everywhere, and I absolutely am, we're doing better in the ER at this. I wouldn't say it's 100% yet, but we're doing way better. And I absolutely see charts here at times where people are mask ventilating with capnography. But it seems like more often than not, the capnography appears later in the sequence, most of the time, not always, once some other device goes in. So the capnography suddenly appears at the same time that or a gain goes in or the T-tube goes in.